Good afternoon, everyone. Hope you're all doing well. Okay, no problem, Paige. Thanks for the FYI. How dare Professor Lack go over? I will have a stern talking to with her. She's still going. Oh, that's funny. No. This is what it is. We got about 4 minutes. At least I get to start on time no matter what. I used to have some people that would go way over. I'd be sitting outside the classroom and that meme of Pablo Escobar waiting around for class to start, and it was always a little awkward. But not to worry, we'll get started on time. People can catch up if they need to. Hey, Nicole. My wife has been binging Bridgerton as of the past couple hours, and so if I accidentally slip into the British accent, you'll have to understand. Oh, here's everyone. Not many people would agree with that, but that's okay. Oh, maybe the show. Yeah, the show seems pretty okay. Oh, you think her exam's gonna be harder than mine? I don't know about that. That's the stroke you're having, Kaylee. It's I have a normal accent. I'll have to do a poll for one of these days to see if I either do it all in the my Putnam County accent or the British. We shall see which one will prevail. Yeah, the Putnam County one is that's the easiest one I slip into when I go home. Like stress induced, like mini strokes. Yeah, I could see that for sure. I could do both at the same time. I was trying to think of a phrase that I could say in the British accent that would be coming from Putnam County. It probably has something to do with going down to the a place called Hogwaller, where you can take your four-wheelers and airboats and all kinds of stuff. I think my D&D characters sound more like Carl Urban from The Boys. Sounds more roguish. Anyway, anything I can do to entertain you guys and keep this stuff a little more interesting. What kind of accents do you guys use to study with? Not good ones. Oh, that's sad. You talk about the aluminium hydroxide used for easing the aches of the stomach. I had a really hard time one time I'll get started in a second here, but one time we went to Ireland for a vacation before we had children, me and my wife, and I was struggling not to do the accent while I was there. And we had this one like Airbnb we stayed at, and the guy was, or no, it was a hotel, and the guy was getting ready to check us out. He goes, "Oh, what room are you in?" I say, "Oh, we're in 333." He's like, "Oh, 333." I about lost it. That was not very culturally sensitive of me, but it was pretty good. Anyway, let's get started here. All right, so we did have one question that came up. Someone, awesome, I'm glad you got 400 steps in. Good for you. Someone asked about my experience after the second dose. It was fine. I got pretty sore on my arm. I had a nice little welt there. And then about 24 hours to the minute, I got like just miserable feeling, just pretty fatigued and not feverish, but just kind of achy. So I took some ibuprofen and Tylenol, and then I was fine. So it wasn't bad. I do love a good Scottish accent. I like Mike Myers' version. But anyway, so of course, if you have questions, pop them up in the chat or on the sticky board there. Anyway, I want to continue on. We were talking about our opioids, right? Opiates, opioids, kind of two names for the same thing. I'll probably slip between the two. Anyway, so these are naturally occurring, or we actually have some synthetic versions as well, that you'll see that basically anything activating the opiate receptor that we have in the brain, in the spinal column, basically any of the CNS, is going to be an opioid basically. So we have three main receptors here. We have mu, kappa, and delta. For our purposes, we're just going to focus on the mu. It's probably sacrilege to my wife who, you know, specializes in pain management, but I'm not going to focus on those other two because they kind of just muddy the waters to a bit. And clinically speaking, they're not as important as the mu. Sometimes you may see it as referring to OP1, 2, and 3, but I'm going to stick with the mu nomenclature because that's just what I've been doing most of my career. So then we have basically, you know, we talked about kind of the stepwise approach to pain management, and these are more used for moderate to severe pain. You don't want to bust out the opioids just because, you know, someone stubbed their toe or something, unless maybe their toe totally broke off. Then that might be appropriate there, right? Anyway, so we were talking about how things like our NSAIDs work to treat pain at the actual site of injury, right? Because they actually deal with the inflammation there. However, the opioids are going to be more so working on blunting those pain signals traveling up through the spinal column, so you can see the mu receptor there, and then also they're going to work up in the brain. I've not have not much experience with opioids myself. I think I got, there's a really wimpy one called Darvocet, and when I had my wisdom teeth taken out, I had a few there, so I didn't really get much out of it. And honestly, the Tylenol did just as much. But I had a teacher in class when I was in school that described it as you still feel the pain, you just don't really care that it's there. And so that's always been kind of the best way to describe it that I've heard. So it doesn't totally eliminate the sensation of pain, but it at least will blunt it and make it much more tolerable for the most part. In terms of the effects we're going to see here, the mu one, as I mentioned, is sort of most important for our purposes. This is where you're going to be seeing inhibited transmission of those pain signals going up into the CNS. They're also responsible for the main, you know, clinical effects of the analgesia, but we also get sort of a lot of the side effects. So things like the constipation, we see things like the respiratory depression, but also the euphoria, right? This is going to be activating our reward pathway where you can actually see that dopamine release happening there that causes people to potentially become addicted, right? And so this is why I focus on the mu, because this is kind of the most important parts of the opioid actions that we're going to look at. And so we're going to see that in terms of their activity, we're mainly going to be divvying it up based off of how it works at the receptor. So we'll look at most of them as being full agonists. We'll find a few that are partial agonists. There's even a few that are kind of weird agonist antagonist types. I'm not going to focus on that too much, but second most important out of this list is the antagonist, right? Because you have someone who has too much opioids on board, you need some way to block that. You need some way to be able to reverse that. And we'll see the agonists are going to be the most commonly used one we're going to run into. Now, some things I want to get into a little bit, and you may have gotten this from Dr. Austin's lecture. Oh, no problem, Nicole. That's fine. So when we're discussing things like addiction, dependence and tolerance and things like that, I think it's important to understand sort of the differentiating factors here. And again, if you probably have gotten some of this during the substance use education, so at least I'll put it into my own words, and perhaps I can give you just a bit of a different perspective. Physical dependence is something that's going to happen to anyone who's on opioids for any long period of time. If it's a few days post-surgery, probably not going to be an issue, but certainly this is something that is expected and we just know is going to happen. This is not actually addiction, right? Your body becomes used to having those extra mu effects around, and it's going to be sort of thrown out of equilibrium if you discontinue it abruptly. And that's why withdrawal is such an important factor of why a lot of people stay on these opioids for so long, because the withdrawal effects are so miserable. They're going to get nauseous, their whole GI tract's going to wake up, so you can see diarrhea, they're going to be feeling miserable. Note, however, it's not fatal. We've talked about a few things that withdrawal from can be fatal. So for instance, your barbiturates, your benzodiazepines, alcohol withdrawal can be fatal. In this case here, it's not going to be fatal. They're going to feel miserable. They'll probably wish they were dead, but they shall not die from this, most likely, unless they vomit and aspirate a huge amount of gastric content or something like that. But again, this is something we expect to occur, and this is not going to be correlated with addiction. Addiction, however, is a psychological dependence, right? So not necessarily physical dependence, but psychological dependence, in which we see a lot of behaviors. And sort of the most succinct way I've ever heard it termed would be sort of continued use despite harm or despite negative consequences. And so you're going to see a lot of that craving, that compulsive use, but basically they are impaired in terms of how they're able to control their drug use. There's different ways you can talk about things like, habituated using and experimentation, but this is falling like they got to have it because their brain just craves it so much because that reward pathway is not being stimulated unless those drugs are around, right? Tolerance is another thing that we would expect to find over time, in which the body sort of gets used to these effects of the medications here. Now, some things you're not going to really get tolerance to. So for instance, once you get started on opioids, you're going to be constipated as long as you're on those opioids. That's just a known fact that never really goes away. However, some things like analgesia tend to develop tolerance over time. And so that's one of those things why you see people who are on escalating doses of opioids, especially over the course of years and years. And there's been cases where, for instance, say you have, a little old grandma, that's, kind of typically what I think of, 90 years old, who's got like terminal cancer, and she's worked up to like an amount of morphine that could kill a horse. She can tolerate it. She's been on that dose for years and she's worked up to it. But there's been cases where like kids will go and will take medications out of the cupboard thinking, oh, wow, here's some morphine. If my little old grandma can tolerate it, surely I can too. And not realizing that she's developed tolerance to all the respiratory depressant effects and CNS depressant effects. And there's been cases of death like that before. So we do want to be really careful. I actually had a case where this is like a not directly related to me, but it was the brother of a cousin's wife or something. So it was a pretty distant relation. But he had an opioid use disorder. He was addicted to heroin, and one of the things we find as well is that a lot of the heroin we find nowadays on the street is actually laced with fentanyl as well. We'll talk about fentanyl in a moment. But it's one of those things where people sometimes will lose their tolerance and not realize it. So to point, he actually went into rehab where he was detoxed from the medications and had gotten to a point where basically his body gotten back almost to baseline in terms of not having any opioids around. And then what happens, that psychological sort of addiction kicks back in. He went back to his normal dose of heroin that he used, and sure enough, he had lost all that tolerance and ended up dying from the first dose back, right? Because of the fact that he lost all that tolerance. So this is something that's important. It's important to understand how things change over time in terms of exposure to their medications. Jackson, so my cousin died, got clean, lost the tolerance, and then relapsed and OD. Yeah, so it's unfortunately a more common story than you might think. I'm sorry that happened to him. And again, it's just, this is a bad deal in the U.S. in general. There's a lot of states hit worse than Florida, but we're still pretty bad. And I'll talk about some of the changes in legislation that have happened here as a result of our particular history with opioids in the state. Anyway, so pseudotolerance is another thing, though, to consider, too. This is where like patients may seem like they have developed more tolerance to the medication, or they're complaining that their pain is not well controlled any longer. A lot of this has to do with the fact that, as you get good pain control, you gain function. You're able to do things again. Maybe that's going to aggravate that injury or that pain that they're experiencing, or their disease progresses. So it seems like, oh, wow, this patient's coming back saying that they're out of their medication because they used it all too early because they were in pain. Maybe they're drug seeking, maybe who knows what's going on. Sometimes it's a change in pain state. Maybe the dose that they were on previously no longer is sufficient for what they're experiencing. So that's something to consider as well. Pseudo addiction kind of goes into that, where you have what we call sort of drug seeking behavior, where patients will come in saying, my roommate stole my medications, or it got flushed down the toilet, or all kinds of different things. That was really, it can sometimes be really frustrating because it's really hard to tell like who's being honest and who's not. Some of these people have a lot of practice at it and can be quite convincing. I always had a really tough time with some of these patients because at the poison center, we would get calls, and when I was staffing on the weekends, we would provide a service where we ID'd medications for people. And so our thought process was, at least as an organization, was it's better for people to have that information and be able to work with that rather than taking pills they don't know what it is, right? So if I bought some pills off of the street and I thought it was oxycodone, which is oxycodone, which we'll talk about in a minute, but it's actually digoxin or something like that, it's better to have that information and not have someone die from that rather than know that it's an opioid, right? So anyway, so I would always have a tough time because I'd have people calling in that say, hey, I need to know what this medication is. And I say, okay, first off, like, has anyone taken this medication? And so they'd be like, well, my dog got into it. And I go, okay, so your dog got into it. I knew full well already what it was. It was, an OxyContin. I said, okay, well, your dog could die from this. Are you sure that the dog actually took it, or are you just trying to figure out what it is? And they started, of course, swearing up and down the dog took it. So you're giving all this information, but really they didn't need it. They just wanted to know what it was. And it's like, there's no legal ramifications for calling. But so there's a lot of, kind of behavior that goes along with this, with some of these issues here. But anyway, sometimes you'll find these patients will be presenting and they're experiencing or exhibiting some of these drug-seeking behaviors, but it's actually related to undertreatment. They're not actually getting this stuff under control in the first place, maybe due to providers being hesitant to use opioids or other appropriate pain management steps, or things have changed for the patient in terms of their pain state. And again, if you could tell the difference 100% of the time, you'd be a billionaire because you'd have a pretty good system there, but it's really difficult to tell in a lot of cases. So the question is well, is the patient experiencing addiction, or are they having appropriate use of the medications? And typically patients who are getting good pain management, they gain function. They're able to go back to work. They're able to see their grandkids and pick them up and do the things they want to do. On the other hand, you typically see patients who truly have an addiction issue. They lose function. They're losing jobs or losing relationships with family members. They are deciding to spend money on their addiction rather than feed their kids. Like, there's a lot of those things. So those are kind of the things that we think about in terms of trying to differentiate between these two here. And again, physical dependence is known. Just because someone's physically dependent on opioids and they're having withdrawal symptoms when they're not present doesn't mean they're addicted. It just means that they've been on those meds and that's what their body is used to. And again, the incidence of addiction can change wildly depending on the population you're talking about. And again, there's a ton of factors that go into it, genetic and otherwise. So again, it's just really tough to predict who's truly addicted, so to speak, and who has normal use of the medication. Anyway, some ways we can help out with that include a program called EForce. And so this is something that is relatively new to the state of Florida, and as compared to a lot of other states. Florida tends to be pretty slow to get on the wagon with a lot of things. You'll see that too when I talk about the ability even for PAs to prescribe opioid medications. It's a relatively new phenomenon, and this kind of goes along with that. This is a system. So use it all the time. The ER is really helpful. Yeah, so this is a really good system. If you're not familiar with it, I encourage all of you to sign up for, or whatever state you go to work in, sign up for its equivalent. And basically it allows you as a healthcare practitioner to look up the patient's information to find out any controlled substance that they've been filling within that state. And it'd be nice if we had a national registry, but we don't. But anyone who's filled within that state for a certain period of time, several years. And so the benefit of that is you can say, okay, a patient comes in. Yeah, so so you can see here, EForce, so Electronic Florida Online Reporting of Controlled Substances Evaluation. It's a bit of a mouthful, so we just go EForce with the S there. So, but anyway, so if you use it, you can look up a patient's information and say they come in and say like, oh, I'm out of my medication, I ran out, something happened, and you look them up and it looks like they're filling appropriately. It looks like they've, they get it every single month, they get it at the same pharmacy, everything looks up to snuff. Then you can say, okay, this patient maybe have a legitimate pain concern. But let me show you another scenario that I ran into a couple years ago. We had a lady, I'm not sure if I told the story already, but we had a lady who was in the peds ER, and she was an adult patient, and normally you wouldn't see that. Typically, you would see that if an adult's in the peds ER, it is due to something happened. They had chest pain or something happened to where we need to get them stabilized, and we'll get them shipped out to an adult facility. So it was not totally uncommon, but it was a little odd. And I saw this lady was getting a dose of Dilaudid. Dilaudid is hydromorphone. It's a pretty heavy-duty painkiller. And I said, wow, that's really odd. I wonder what she's here for that she's getting Dilaudid. I mean, if you're coming in for chest pain, you might get some morphine, but like Dilaudid, that's odd. So anyway, so I was looking it up because I was processing the order, and it said, patients here for kidney stone pain. Same thing happened 2 days ago. Kids in the hospital. I said, that's a little strange. That seems weird that she'd be here in the ER 2 times, then a couple of days for the same thing. So I decided to, and of course she got Dilaudid last time too. So I decided to look up EForce, because that's, as a healthcare practitioner, that's within my right. So I looked it up, and found out that she was using a ton of different addresses. She was filling a huge number of different pharmacies and just filling huge amounts of opioids. And so I, took it over to the doc, and he's a PDR guy, so they may have a little less cynicism built in than the adult ER practitioners. But I said, hey, did you check out EForce in this lady before you wrote for the adult? I did. This is like the second dose she was getting, and he goes, no, I didn't even think to do that. So I showed it to him, and he goes, oh, I can't believe it. She was lying to me. And I said, well, I mean, they get pretty good at this stuff. And I mean, even, complaining of kidney stones, you can fake a UA and put a little bit of blood in there, prick your finger or something. But so anyway, so it was decided not to give her any more pain medication, got her shipped out, and then we, basically made sure it wasn't going to happen again. So again, it's one of those things where that's an additional tool. Again, it may not be the perfect tool, but it is useful if you can take it to them on paper and say, hey, what's going on here? So Kaylee was saying, working in pain management, hardest thing was when we had to take over patient care from a clinic that got shut down because most of the time they were over prescribing and had to be tapered down. That is rough. Yeah, and I'll talk about that briefly here in just a moment. We talk about some of the law changes. Marley's asking, out of curiosity, in the peds hospital, do you often encounter parents trying to take their kids' pain meds? I have seen that a few times, unfortunately. It's really sad, especially like the sickle cell patients. You'd have kids who would come in for like acute pain crises, and you'd say like, man, what's going on? Like, is their pain just not under control at home? You do like a urine drug screen on the patient, that'd be negative. They'd have no opioids in their system whatsoever, and so then you'd figure out, okay, well, obviously someone's taking the medications, if not the child, and might likely the parent, or could be selling it or something like that. So it was unfortunate, but it does happen on occasion. Had a 60-year-old frequent flyer in the ER who did the same. You'd never guess by looking that she would do that. Yeah, exactly. So it's, again, people, but it can be deceiving, as it turns out. So I wish I had a more if I said it in the accent, would that be more or less depressing, I guess, is the question. You guys probably wouldn't pay attention, then you'd just be laughing at my poor attempt at accents. Anyway, so a big change that happened in the past couple of years is House Bill 21. So this was something that applied to controlled substances. So just for background, in Florida, we were known as sort of the first stop on the Oxycontin Express, and I encourage you to look this stuff up if you're interested. Basically, we had a huge number of doctors' offices that would be basically known for overprescribing opioids to these patients here. I mean, you go down to, it's usually in a strip mall. You go in there, the entire parking lot would be full up with license plates from like Virginia and, Tennessee, all these places up and down the coast. And basically they were there to get these huge amounts of opioids written for them. They would then go to the pharmacy, and maybe sometimes these providers would have pharmacists who were in cahoots with them. Some pharmacists were involved with this too, and just fill for huge amounts of oxycodone, typically OxyContin, and then that would be shipped out of Florida and distributed out in other places, either for people to take themselves or to sell to others. And so this is a big deal. It was a huge problem. You can actually look at graphs, and I don't have one here, but you can see sort of the trends in prescription drug abuse for Florida and how it changed, because one of the big things that, that was Rick Scott or someone else, but basically they came in and they shut all these pill mills down. And it's wild too, because I actually was able to talk to a couple of officers for Florida Department of FDLE, yeah, so for Florida Department of Law Enforcement, and they were undercover officers, and they would actually go into these pill mills, as they were called, and try to get illegitimate scripts written for them in order to get evidence against these providers. But I mean, you'd have like doctors who had like guns in their offices in case, they got into trouble or something like that. There's some providers who were trading sexual favors for prescriptions, and so it's like LabCo had like condoms in it. Like, it's just awful stuff associated with this. So they really cracked down on that really hard, trying to get rid of all these pill mills. And so, all of a sudden, all the opioid abuse in Florida just went away, right? Well, not really. Unfortunately, what it ended up turning was that it ended up switching over to a lot of heroin use, and now we're seeing a lot of fentanyl deaths associated with that, because many of the samples of heroin we find nowadays are also laced with fentanyl, so a lot of issues with that. Priya saying there's an American Greed episode about two brothers at a South Florida pain clinic who made $40 million on overprescribing oxy. Insane. I agree. Crazy they get away with it for so long. I agree. Certainly crazy. The Pharmacist. It was all about that and super interesting. Oh, I didn't watch that. I think I should probably check that out though. But yeah, it was pharmacists, doctors. A lot of people were involved in that. It was unfortunate. There's even a case like where there was this like really old doc who was, you know, should have retired years ago, but he got sort of coerced by these this couple that basically kind of used his license in order to distribute this stuff, and it was really sad because the guy was really, you know, he's pretty senile and didn't really know what was going on. He thought he was taking care of people, but yeah, fentanyl is really nasty too. We'll talk about that in a little bit. It's a good drug, but it has some issues. Anyway, so that's the background on why we were cracking down on this so hard. And so eventually we got to the point where we have this bill now, and this is basically applying to all controlled substances. It basically says, and it basically extends the ability for PAs and MPs to write for controlled substances outside of like a hospital setting. Usually in the hospital, you're writing underneath like the hospital's DEA license, but this is what allowed you to now do it, you know, under your own DEA license, basically. But you have to have some training associated with this. And part of the restrictions was a big one saying that you have to check EForce prior to prescribing. Now, how they monitor for this, who knows? But, you know, a lot of times institutions would do this on a case-by-case basis, like hospital to hospital. And then they made some limits in terms of how much you could prescribe, because there'd be cases where people could write for like, you know, 2 weeks worth of oxycodone from an ER for an acute pain issue. And it's like, well, that's not, doesn't seem legitimate. But they put these restrictions on here where they say now that it's a 3-day limit for any opioid pain medication, and you can extend it to 7, but you have to write on their acute pain exemption. That's kind of the thing to get that 7-day limit. And then for chronic pain, then you have to write non-acute pain, and then applies, and you can do the normal rules in terms of, you know, doing up to 90 days worth, etc. That was one of the big changes we saw here. Now, again, I probably talked about this briefly before. Let's see. Yeah, a month's worth of hydrocodone for wisdom teeth. That's ridiculous, you know. Someone's asking here, do we have to be certified to be able to EForce people? I like that term. I like the idea of using that as a verb. I'm going to EForce you so hard. No, basically, I believe you do have to have a license. I think it's part of what you have to do when you get checked out. So when you actually sign up for it. So I think you have to be certified first, and then you can sign up for EForce. But I was already a pharmacist when it came out, so I cannot speak to that necessarily. Anyway, so when talking about controlled substances, remember that there's 5 levels of control. Oh, the inmates could use it. Interesting. They have to be, yeah, you have to be registered under a provider. Okay. Yeah, so there's probably some restrictions to that. Oh, interesting. I didn't realize scribes could do it too. That's cool. Very good. Yeah, some of you already have the ability to do that. Obviously, do not use that for any sort of personal reasons. That would be a huge HIPAA violation, obviously. But anyway, so yeah, that's awesome. I guess yeah, it's a little bit more broad than I thought. So it's good you guys had that ability. Helps because you can kind of relieve that off of the provider to be able to check that out while they're doing something else. Anyway, so remember there's C1 through 5. 5 is sort of the wimpiest. C1 is going to be sort of the most controlled. Remember, C1 basically means that it has no acceptable medical use, but has a high risk for abuse and deterrence, right? Or not deterrent, what am I thinking of? Now the word is completely escaped me. Diversion, there we go. Yeah, it's abuse and diversion. Diversion is like where like a healthcare provider would like take medication, either use it for themselves or sell it or something like that. So C1s would be stuff like, you know, federally marijuana is still considered to be a Schedule 1 substance. Stuff like MDMA or ecstasy is considered a Schedule 1 substance. Heroin is a Schedule 1. There's no acceptable medical use for it, and it has a high rate or high risk for abuse and addiction. The C2s are going to be the ones that are the most controlled, that you have access to prescribing as a PA. And so this includes like, you know, your hydrocodones, oxycodones, etc. Cocaine technically fits as a C2. All of your amphetamines that you use for ADHD, all are considered C2s as well. Then it goes down from there. So for instance, like ketamine's a C3, all your benzos are C4s. So, you know, various degrees of control on that stuff. And remember, 2s are going to be no refills, only up to 90 days at a max. 3 through 5, you can do up to a total of 6 months in terms of refills and supply for that. So just remember to keep those distinctions in mind there. I'm probably not going to ask you specifically on a test like, okay, which one of these is a C2? Like, I don't really care if you know that because you can look it up. But, you know, to remember those distinctions between prescribing C2s and 3s and 4s, because that does have practical implications for how you work, right? How you practice. Anyway, so let's get into the opioids themselves. Codeine, which is frequently found in combo with Tylenol, that's where we get the Tylenol number 3 from. This is an interesting one because by itself it's kind of a wimpy opioid in terms of analgesia, but what you can do is actually run it through the liver, and 2D6, 2D6 will convert it over into morphine, which is a very good analgesic. And so what's interesting about this is the fact that you end up finding that there's a large amount of differences in terms of like how well patients can express that CYP2D6 and how able they are to convert codeine over into morphine. So people that have like an enzyme deficiency, they're not going to be able to convert it over as well. So codeine probably doesn't work that well for them because they can't convert it into morphine. On the other hand, hyperactive in other patients, and you actually found that yes, they get more analgesia from it because they have more morphine being formed, but also more side effects. And of course, my classic example is in this idea of using codeine in kids who just had a TNA that happen to be ultra rapid CYP2D6 metabolizers. And again, this is something that you can't just look at a person and tell, and it's not something we routinely test for. But you'd have these kids who had OSA to begin with. They were getting tonsils taken out, and so their airway was a little bit swollen anyway due to surgery. And then now they have all this morphine flooding their system because they're converting it over very easily from codeine, and they had respiratory depression and died. Because of that, we really don't use it in peds anymore. It's really fallen out of favor from that. And this is going to be more for like mild to moderate pain. I really wouldn't use this for someone who's got like a fracture or just got surgery or something like that. And it can range between a C5 and a C3 depending on that formulation. So again, I'm not going to ask you very specifics on the controlled substance, just for your information there. Interestingly enough, though, the people that are more likely to be ultra-rapid CYP2D6 metabolizers happen to be those of either like Middle Eastern or North African descent. So you may find those patients respond better to codeine than other patients. Say like typical white patients may not respond quite as well. So interesting how our genetics can play a role in terms of how well we respond to a drug. So getting into morphine, there's a lot of different forms that are out there. Morphine's kind of the first one here that has like, we use IV quite frequently in the hospital setting. But certainly there's a lot of oral forms that you can find as well. And here's an example where we have both immediate release and extended release formulation. So for instance, if you ever hear the term MS Cotton, that's the brand name for the extended release preparation that's supposed to last, 12 hours or so. Again, remember extended release preparations are good for basal pain control, and then you have immediate release versions on top of that for breakthrough pain on an as needed basis, right? Now, there are some metabolites of this that can have some issues, and so notably, you can actually find these metabolites are renally cleared, so it's kind of nasty in terms of side effects for elderly patients, especially those with renal failure. They tend to accumulate these metabolites, which in the case of morphine 6-glucuronide has more analgesic properties than morphine does. So you can find these patients with renal failure who will then build up levels of the metabolite and can actually get into some trouble there in terms of CNS and respiratory depression. So you do got to be really cautious with those patients there. If they have renal failure, I'd avoid using morphine for like long-term use. If it's a single dose or so, it's not going to be a problem. It's just a matter of repeated chronic dosing. Now, notably with morphine, this is something unique to this one, is it causes a significant amount of histamine release, which means some patients will develop itching with this, maybe a little bit of rash. This is not a true allergic reaction, right? This can be treated with antihistamines. Now, what's the problem if you mix antihistamines plus morphine? Well, they're both pretty sedating, so you can really run into some issues with that. However, I'll show you a variety of different options we have. So if someone says, oh, I have a history of morphine allergy, and you say, well, what was your allergy? They say, oh, I got really itchy. Okay, well, that's not really going to be a true allergy in this case here, but you could switch over to a different opioid and avoid that and not have that histamine issue, right? Two, you can actually see hits on their blood pressure due to the histamine causing that vasodilation, so you do want to be cautious in the hypotensive patients too. They may be more susceptible to that. Someone was asking, how well do you know if someone is enzyme deficient or hyperactive, or how well they can convert codeine to morphine? You don't know until you give it to them, really. It's one of those things. And it was interesting, as I mentioned, that North African descent seemed to be more likely to have CYP2D6 metabolizers, because when you see patients who have sickle cell disease who are predominantly black, I've seen a lot of them actually do pretty well on codeine. So it's one of those things where, like, you can kind of surmise, well, yeah, it makes sense that they would do well on it because they can more likely to convert that over into morphine better, right? So they would have better pain control with it. So that would make a sense. But again, the easier thing to do is just not even use the codeine in the first place, because honestly, we have a lot better options. It's kind of wimpy in terms of its analgesia anyway. So unfortunately, I wish I could look at a patient and tell, but you really can't unless you did some, pretty expensive testing there. Someone said, is the ultra rapid CYP2D6 only in patients who specifically had TNA, or is it found in children who needed painkillers post TNA? These were the kids who died from it. It just happened to be this sort of this perfect storm of the fact that they had all this extra morphine on board due to that genetic pharmacogenetic polymorphism. Then they also had that inflamed airway. They were already they had OSA anyway, so they're already kind of like blunted to that CO2 response. And it all just kind of culminated in this patient having respiratory depression, and they died. And there's several cases of it. So again, scary enough that they're just like, let's just not use it. Why even chance it when we have better options that are there? Someone says, why can't you give morphine to hypotensive patients? That has to do with the histamine release, right? So if I had a patient who, say they just like presented to the ER, they're in pain, maybe it's like a trauma, right? So say it's like a trauma, they're in a lot of pain, they're already hypotensive. I don't know why. Is they bleeding? Are they volume depleted? Like what's going on here? If I give them morphine without knowing kind of what their normal response would be, I risk lowering that pressure even further. And then how do I treat it? I have to give them Benadryl at that point. And then it's like, you're just clouding the picture. So someone like that, I'd want to use a cleaner opioid that doesn't have those kind of ancillary effects. So again, that's why I would say avoid it in those type of patients. How would you be able to tell if someone actually was allergic to morphine? You ask them what their reaction was. If it was a little bit of itching, a little bit of rash, I probably wouldn't be too concerned with that. If they're like, oh, I had hives, I had trouble breathing, that is more indicative of a true anaphylactoid reaction, which I would not want to try challenging. And anyway, if I had someone who came in and they said, oh, I have a morphine allergy, and I go, what is it? And they say itching, I'm probably going to skip giving them morphine anyway, right? Because again, we have better options. And I'll show you a few of those in just a little bit. Someone's like, can you remind us again why it's not considered true allergic reaction when someone gets pruritus from morphine? Because it's not like the true like IgE mediated sort of anaphylactic reaction you would expect to someone who has like a peanut allergy, right? Some people do have true morphine allergies, but this is a different mechanism. This is just purely histamine being released as a result of the morphine, someone who's susceptible to that. So a little bit different in terms of mechanism, even though they do share a little bit of crossover in terms that histamine's involved in both, but that's not the full anaphylactoid sort of picture you'd expect to see. Good, I'm glad you guys have questions. Shows me that you're listening. I appreciate it. Let's see here. So anyway, so let's switch gears a little bit. Now we have another pretty common orally used opioid here. You rarely find it by itself. It's a hydrocodone. Normally if you hear like Norco or Lortab or something, but usually found with acetaminophen. So this is why I always harp on the fact that you got to consider all sources the Tylenol patients are getting, because if you forget about something like this, it's very easy for them to go above their 4-gram max, right? Just as an example, there's like a Zohydro ER, which, normal doses of hydrocodone usually range between like 5 to 10 milligrams per pill. I think this one goes up to like 50 to 80 milligrams, which is just like a gobstopping amount of hydrocodone. But these are for patients who are chronically in pain, who have worked up to this over the course of years generally. This is another one that also gets converted into an active metabolite called hydromorphone, which is basically dilaudid via CYP2D6. So again, there could be a little bit of variability in how patients respond to this based on if they're expressing more or less CYP2D6, but this is less clinically significant than what we saw with codeine. So I'm usually less concerned about their CYP2D6 expression for hydrocodone. Very little do I think about that versus with like codeine, which is a much bigger concern with that. And in fact, it was a C3 for the longest time, and that's what actually made it the most frequently prescribed medication in the US for like years. And then we saw, okay, well, wow, this is truly an epidemic in terms of opioid abuse. And what's one of the biggest contributors? Well, hydrocodone's a big one. So let's try to get that under control. So they made it more restrictive and put it up to a C2. So I used to use hydrocodone all the time because it was easier to prescribe as a C3. You could do refills on it. It was just a little bit simpler from that standpoint. But they have now since cracked down on that as making it a C2. In sort of the same category, I kind of think about oxy and hydrocodone sort of similarly acting to one another. Oh, it's a good question, Andrea. We'll get to that in just a moment. So oxycodone, you may see as roxicodone, Roxyset. If you see CET in the name, that usually means it has Tylenol in it, acetaminophen, right?
And then the all popular oxycontin. You know, this is a pretty notorious drug, even though it's good at what it does if you use it appropriately. But there's a lot of really good. If you watch Last Week Tonight, there's a couple of segments that he does, John Oliver does on Purdue Pharma and them producing OxyContin. But there's a lot of really wild stuff that goes into how the drug was marketed and how it was pushed, the way they dosed it and things like that. But I don't want to get too much into it. But anyway, you actually find that it's fairly good as an oral pain medication, either as extended form or for immediate use there. And again, you can find some forms that have acetaminophen with it as well, just like you would see with like a Lortab or a Norco. This one here has, again, a little bit of that CYP2D6 metabolism where it gets converted into something called oxymorphone, which I'm not going to talk too much about here. So again, just know that you could have some issues in patients with that, but again, less clinically concerning, or less on my radar, I should say, than it would be for someone getting codeine, for instance, right? So again, this has always been a C2, at least as far as I know. And so, yeah, it's definitely a big player there. I always know that, it's funny because like when I did a little bit of time in retail during school, and it's funny because people always call, they'd say, hey, do you have any oxycodone? And I was like, well, I can't tell you if we have oxycodone in stock or not because I don't want someone to come and rob us. I mean, I got robbed my second day working in the pharmacy for some Lortab. But anyway, they'd always say like, well, do you have the brand name in stock? I was like, well, why do you care if it's the brand name? Oh, it just works better for me. Okay, sure. The brand name sells for a lot more because you can tell it's brand name OxyContin instead of some generic form. So they always look for the blue ones. That was always the ones that they wanted there, which is strange. To go back to doing those pill identification calls. It was funny because you could always tell when someone like kind of knew what they had, but they weren't quite sure. They were just wanted like double verification on it because they probably had just bought it from somebody. And so they would say, okay, well, it looks like this. And I said, okay, well, it's oxycodone. And they say, oh, well, how many milligrams is it? And I say, well, what do you think if I said it was 10? And they say, oh, okay. And I said, what if I told you it was a 40? And they get steadily more excited as I went up in the dose. Again, you got to find ways to amuse yourself sometimes. But anyway, so that was something you always run into. I always want the brand name OxyContin. Anyway, I always told them the truth at the very end, but it's fun to kind of work up their anticipation. It was almost like, I don't know, winning a prize or something for them. It was very strange. But regardless, again, pretty good drug. You'll see it used quite frequently, but oftentimes it gets abused quite frequently. Anyway, so Andrew was asking, so can someone with a codeine or morphine allergy take the codones, right? So the question about that is you got to think about like the structure of these drugs in terms of their relationship to the parent compound. So when you think about like the poppy plant, you think about like opium, I think about heroin, codeine, morphine. Those all look very similar to one another. You can look up the structures, which I won't bore you with here. But the point being is that they all look very similar to one another. So it's very likely you're going to have an allergic reaction to one versus the other. So if someone said they had a codeine allergy and anaphylaxis, then I would assume that they couldn't receive heroin, they couldn't receive morphine because they all look very structurally similar to one another. Now we get into like hydrocodone and oxycodone. We call these semi-synthetic, and so there's less risk because the structures look different enough. I will tell you the ones that are like totally safe because they look completely different. But notice here, there's not really any mention of the histamine reaction. So if someone said I just had some itching with morphine, they would probably be okay to get oxycodone and hydrocodone. I'd feel comfortable at least trying to give them a dose, see how it goes, and then go from there, right? I'll tell you about the fully synthetic ones in just a few moments here. See, I hated sitting on a scene of a call, counting pills and trying to ID them. Yeah, that's not fun. You should call the poison center if you're ever in that experience again. We'd have police officers call us too, because they just would be on the verge of arresting someone, and they'd find these pills and call us up. And if we told them it was a controlled substance, they'd say, "Oh, all right, getting arrested." And so it was always like kind of a bummer to hear like someone's just getting arrested based off of what we're telling them, but they must have been doing something, I guess. I don't know. Anyway. Getting into hydromorphone or Dilaudid. So this is a pretty common one that you'll run into. This is kind of like in your we talk about like potencies of different opioids, and you can get a wide range of potency here between them. So when you think about drugs like morphine, a typical IV dose, you're thinking something like, 2 to 4 to 5 milligrams an IV dose for pretty standard dose of morphine. This is starting to get more potent, and so again, it's important to understand equal potent dosages between these, which you'll get a feel for when you're practicing. So, for instance, if I were to give someone that had received 5 milligrams of morphine, and then I give them 5 milligrams of Dilaudid, they're going to be out for the count because it's just way more potent of a drug. So I may be giving here between, like, say, 1 to 2 milligrams, for instance. So you can start to see some of those differences there as you're practicing. There's some metabolites here, but clinically they don't come up all that too often. I do like this one on an inpatient basis because it does have a shorter half-life, which means it's better for like titrating the dose. So that way you don't have to worry so much about over-sedation and things like that. So it helps you kind of dial in things a little bit better with that. This one is pretty good to switch over to if someone has bad reaction to morphine in terms of histamine release. Switching over to this, it tends to be a pretty popular alternative. So I see people do pretty well with this. And again, a lot of people, I think, had a bad rap against hydromorphone for a while, kind of thinking about it as being just like something that got abused a lot. That may be the case, but actually I'm starting to see more and more use nowadays for it. Very good drug. You just have to understand that's a little more potent, and so you got to make sure you're adjusting your dose accordingly. Next, we get into the synthetics. Now we got fentanyl here. So hydromorphone is still considered one of the semi-synthetics, which makes sense because hydrocodone gets broken down into it, right? John was saying, I thought a lot of hospitals are trying to remove away from Dilaudid. Is that just in the ER? I think it depends. You'll find that practices differ from place to place and even, region to region. I know at least for our pediatric patients, we don't really shy away from Dilaudid. It tends to be a pretty good one. A lot of our sickle cell patients respond really well to it. So you'll see a lot of them on Dilaudid at home, and then they get converted over to IV Dilaudid in the hospital. So it really just depends on the providers and what they're comfortable with, I think. But so, you always have those people that come in and say, oh, I'm allergic to everything. I can't get anything except the Dilaudid. That's what works for me. Okay, well, maybe that's the case, but maybe you can look for some other options. Man, try a dose of Toradol. See how that works for you. Oh, no, I'm allergic to Toradol. Wow, that's so interesting that happened. Yeah, so someone's asking, do oxy and hydrocodone both lack the histamine release? Yes, they also avoid that as well. So really morphine is the big culprit for that. And again, when I think about like my typical like oral opioids, I'm thinking like codeine, morphine, hydrocodone, oxycodone. When I'm thinking IV opioids, I'm thinking like morphine is a pretty common one, hydromorphone, fentanyl. So you'll get a feel for that too as you're practicing, saying, okay, what are the common IV ones? That way you can kind of know like which ones to switch between and common oral ones. Now let's get into fentanyl. Fentanyl is pretty interesting. It is what we consider a fully synthetic opioid, meaning it has no structural similarities to the original poppy plant or any of the compounds found within. It's also really potent as compared to morphine. So as an example, 4 to 5 milligrams of IV. Oh, sorry. Thank you for reminding me because I'm silly. Anyway, so with fentanyl, 100 times more important. See, can you go up on my dose? Of course, we can try Toradol addiction. Yeah. So with fentanyl being so potent, consider an IV dose of morphine to be like 4 to 5 milligrams IV. To get an equivalent fentanyl dose, you're doing like 1 to 200 micrograms. Not 1 to 2, that'd be a very low dose, but 1 to 200 micrograms. So you can imagine the difference between going 5,000 micrograms of morphine is equivalent to about 200 of fentanyl. So you can see the difference in potency there. There's also a lot of dosage forms that are available for this. And so we have IV, we have transdermal, there's even transmucosal. Here's an example of the fentanyl lollipop, as they call it. It's called Actique. And that way, that's a way that patients can titrate their dose. So if they're feeling pain, they can stick it against their cheek. And then when their pain goes away, they can take it away and vice versa. And we even use a lot of intranasal fentanyl. It's actually a really good pain reliever if you don't have an IV established. We do that quite frequently for our patients in the ER. So you can find it either used IV for acute pain. So we use this all the time in surgery, and I think that's where most people are probably familiar with its use as surgery. I think now in the ER it's getting more and more popular. And then the long-acting forms like the transdermal, like the patches, are better for more chronic pain issues. But this is like a stalwart choice if you're going to be like intubating a patient and putting them on sedation. Oftentimes it's like fentanyl and Versed. Like that's a classic combo there for meds to keep patients sedated. Oh, sorry, someone's asking, sorry if I missed it, what does TNA mean for black box warning for codeine? That's a tonsillectomy and adenoidectomy. So they go for ENT procedure, have those tonsils removed, and then have that swollen airway, and then die from the excess respiratory depression and with all of that. There's 3 other forms, and my dad's a CRNA, so of course I get most of my terrible humor from him. But he always talked about the fentanyl family, and so this is how I remember this. He always say there's Al, Sue, and Remy. So these are congeners or within the same fentanyl class, but they have a little bit of different actions there. So alfentanyl, sufentanil, and remifentanil. You'll primarily just see these in surgery, and you'll find some providers like it better for some things than others. For instance, like our cardiac surgeons who are doing open heart surgery, they love sufentanil. Most of our anesthesiologists like remifentanil. It just depends on the cases in which they're using it in particular. But the benefit of using something that is fully synthetic is if you have someone that does have a true allergy to any of the phenanthrene, kind of the chemical classification of things like morphine, oxycodone, etc., this is totally safe. So if I had someone who had a true anaphylactic allergy to morphine, hydrocodone, oxycodone, anything, you can usually get away with fentanyl as a pretty safe alternative there because they just don't look alike to the body, and so they should not have any sort of a similar reaction. And again, you're seeing a ton of fentanyl being laced into and a lot of the heroin samples we see nowadays. So again, fentanyl overdoses, whether intentional or not, are quite common. The other thing to note too with the patches, you want to be really careful. One thing to always consider, and I know this is more of a physical diagnosis thing, but when you are dealing with a patient, say they're presenting for altered mental status, and you're not sure, could there be a drug exposure, could there be trauma, could be something going on. Super important to make sure you're doing a good head-to-toe examination, including removing clothing and looking for stuff like patches, because you could find a clonidine patch, you could find a fentanyl patch, and that could be the smoking gun, so to speak, in terms of what's causing your patient's issue. You got to look for that stuff and make sure to get those removed if appropriate when examining patients, right? That's why it's important to actually dress them down so that way you can look and find these sorts of things, including whatever else you might be looking for. Anyway, methadone's a pretty interesting one here too. So methadone is its claim to fame for the longest time is what it was used as treatment for opioid use disorders, right? So if you wanted to switch someone, say they were using heroin or oxycodone, whatever the case may be, you want to switch them to something that they could eventually wean down off of and be done with opioids. Methadone was kind of it for a really long time. And the reason for that is the fact that it has a super long half-life. Stuff like hydromorphone is pretty short half-life. Fentanyl is really, really short half-life. This is like over 50 hours. So what the benefit of this is that at the time when you had these methadone clinics, you still do have them, they'd be open Monday through Friday. So the goal is that patients would not take home a prescription for this, but they would go in and actually be observed taking their dose of methadone. So it's called direct observed therapy. They'll go in Monday, Tuesday, Wednesday, Thursday, Friday. They would build up levels throughout the week, such that when the clinic was closed on the weekend, they had a pretty decent level of methadone still built in, such that as the weekend went on, their levels would start to taper, and hopefully they would not get so low that they would have withdrawal symptoms and then relapse and go back to their opioid of choice. So the benefit of that is when Monday the clinic opens back up, everyone's there to get their dose, and then they're good to go again. Okay, so that is what it's been used for a long time, but it's because it has a good long half-life, it's also really good for chronic pain as well. So we're starting to see more and more use for patients who have like long-standing chronic pain, like cancer and things like that. So it's not unreasonable to see someone on a methadone prescription. You don't automatically want to assume it's for addiction purposes, but it could be for pain purposes. We do this a lot too. In the NICU, if we have patients who are born with what we call neonatal abstinence syndrome, so the moms are abusing opioids throughout the pregnancy, and then the kid's born, they're going to go through the same withdrawal as soon as they get cut off from the supply, mom, as any other person would when they're cut off from their opioids. So we would sometimes use methadone as a long-acting opioid in order to slowly wean them down off of that until they were basically fine to discontinue it. But other neat things about methadone, it also has this reuptake inhibition of norepinephrine and serotonin. That should sound familiar to you with a lot of your antidepressant medications. Probably has some activity against NMDA as well, but that's kind of besides the point. So there could be some use for this in terms of like neuropathic pain because of those actions on norepi and serotonin as an example. Methadone is really tough to use, even for practice pain management providers. They can have a tough time because there's a lot of conversion ratios between different opioids and things like that. But from an overdose standpoint, one thing I'm really concerned with is QT prolongation, which you can definitely see with this. So make sure you're checking EKGs and electrolytes prior to starting to make sure they don't have any prolongation issues to begin with, and certainly an overdose, you would definitely want to watch out for that. Really careful evaluation. This is probably not something you guys are going to be prescribing. This is more like something they're going to be getting from the pain management clinic specifically. However, what you may be more likely to prescribe, I'll talk about in just a minute. I thought it was the next slide, which would have been a good segue, but I am bad at segues, so it is what it is. Someone said, should we know the metabolites of each drug? It's broken down, for example, codeine to hydrocodone. I would know the codeine one very specifically just because it's morphine, but I would know some of the issues you might run into with the metabolites for the various ones. I'm probably not going to ask you. It's fairly easy because most of them are like either another drug that we covered as a metabolite, or it's like it's got the name of the drug in it specifically. But like the morphine 6-glucuronide, like I would know that that's pretty potent in terms of analgesia, and that it gets accumulated renal failure and stuff like that is good to know, I would say. Okay, so switching back. So next up we have meperidine. The brand name was Demerol, and I always had this pain management pharmacist in school who called it Demonol. She hated this stuff so bad. It almost is never going to be used for the most part. We used to use it for pain all the time, but unfortunately it has this metabolite that tends to build up in patients who have renal failure. And so you can see a lot of seizures and sometimes cardiac disturbances along with this. But the seizures are really bad in these elderly patients, so we really recommend avoiding it. It also inhibits monoamine oxidase as well, so it can interact with like depression medications and stuff. So it's a bad drug. However, what we do use it for occasionally is going to be for rigor. So if you have a patient who is shivering, either due to surgery or, for instance, if we're trying to do therapeutic hypothermia, where you're trying to cool the patient down after like a cardiac arrest or stroke or something, this can be useful because specifically in the case of hypothermia, if a patient's shivering, that's being done to raise their temperature back up. And so they're kind of fighting the therapy that you're trying to initiate. So we can do meperidine along with some paralytics and stuff and try to nip that in the bud and keep their temperature down where we want it. So that's a rare case you're going to see it. I would not use this or recommend it for pain ever. Then we have buprenorphine, Suboxone, Subutex, a couple different brand names for that. This is another really long-acting agent. This one's really pretty interesting, and you should have learned about it in the substance use education. But basically, this is a really long-acting partial agonist for the mu receptor. It has a really tight affinity, but it only partially activates the mu receptor. So, like, think, why would I do that? Point being is that when you give this, let's say you have two different phenomenons that could happen. You got someone who's like taking a normal opioid, normal full agonist. Let's say I'll give you an example here. Here's a lady we had that came in a couple years ago. EMS calls and say, hey, we got this so-and-so-year-old lady. She's coming in for a buprenorphine overdose. Be there in 3. I said, okay. In my mind, I always try to picture what that patient's going to look like rolling into the door. I'm sure you guys will do the same thing too when you're working. And so I assumed it'd be someone who'd be quite sedate, who would be maybe intubated, who knows, right? But that's what I expected. This lady came in and she was spitting, she was cussing, she was like trying to rip people's shirts. I mean, she was just really turned up to 11. And we're just like, what is going on here? Why is this lady so wild right now? This does not look like a buprenorphine overdose. It looks more like a angel dust or PCP or something overdose. So anyway, so we got a little bit of Ativan on board, calmed the lady down some, and we're just like, what was going on? Like, what happened to you? And so anyway, she takes methadone for opioid use disorders, but she might have been taking a little more than she was supposed to. But basically she ran out. And so she needed some sort of source of opioids because she didn't want to go into withdrawals. So she took her roommate's buprenorphine, not realizing that by taking a partial agonist with a really high affinity, it kicked all that methadone in her system off of the receptors. And then basically, instead of being at 100% opioid activity, she's now down to 50%. Well, what do you expect to happen? Well, that big reduction in activity means she's going into withdrawal. So what she's presenting as is what looked like an amphetamine overdose or something was just like severe opioid withdrawal. And so once we figured that out, that, okay, the buprenorphine is a culprit here, that made a lot more sense based on the kinetics of it, right? Yeah, so that's why, you should maybe Google this stuff before you take your roommate's opioids, right? Jeez, it's just good safe information. Don't do drugs. That's ultimately what it comes back to. Anyway, so there's that. So that's the improper way to use something like buprenorphine. The proper way to do it is to have someone who's on their opioids say, okay, stop taking your opioids today. And then when you start to have withdrawal symptoms, that's when we initiate the buprenorphine. Because the goal is to ameliorate those withdrawal symptoms, with something that's only going to give you partial agonist, so you don't get the full euphoric effects of it, but you also don't have the withdrawals, hopefully. And then you can gradually titrate them off of it. And if they go back and say abuse something like heroin on top of this, the heroin has a lot harder time binding to those receptors and it doesn't work as well. So they don't really get the same kick out of it as they would expect because that buprenorphine is occupying those receptors. So that's why we use it for opioid addiction. And that's why you guys can get those X waivers on your license along with a DEA license in order to be able to prescribe this, because it is not relegated just to pain management clinics. You guys can use this in family practice and internal medicine, things like that. So pretty interesting. So this is why we use it. Long half-life, partial agonist, tight binding affinity. Note you would not ever use this for pain because, again, it doesn't really give you the full activity you're looking for, so it doesn't make a good option for that. I really don't like this stuff in terms of like toxicology, because I've had cases where a young kid would even get into like one tablet, like 8 milligrams Suboxone, and like had to be intubated, and was the half-life was such that they're out for like 2 days basically. So pretty nasty from that standpoint, but good for opioid use disorders. This Suboxone, if you ever see that, it's actually compounded with naloxone. It's an oral product, but the goal is to deter IV abuse of the medication. So if you were to inject this, naloxone keep it from working, right? Which we'll talk about naloxone here in just a moment. Basically, when you're trying to pick your opioids, you're doing it based off of the pain intensity, pharmacologic factors that go into this, what kind of coexisting conditions it may have. And remember, for persistent pain, long-acting, plus or minus short-acting for the breakthrough pain issues. That's going to work for most patients there. You may be on oxycodone 2 or 3 times daily for basal pain control, and then on immediate release morphine, Q4 hours, PR and breakthrough pain, right? That could be an example of something. You can mix and match opioids there. Generally, we're going to go oral where possible. For transdermal, specifically fentanyl, that's a long-acting effect, so that's going to be for chronic pain for those patients there. And as I mentioned, like intranasal fentanyl, because it's good when you don't have any IV access, so very beneficial from that. Now dosing should be individualized, and generally I go with the idea of start low and go slow. And you can titrate up as needed. You can always give more, but you can't take it back. Professor Q has a good analogy when he's talking about pain medications. He says, like, you're like a magician, right? You're coming out there and you're putting on a show for the patient. You don't want to start by sawing the lady in half right off the bat. You can't start the show with the showstopper. So you work them up a little bit. Here you go. Have some Toradol. Let's see how that works for your pain. It's like pulling the rabbit out of the hat. And if you need it, then you can go and bring out the big guns as necessary, right? So again, you can always give a little more. Harder to take it back, as it turns out. Someone said, do you ever see treatment for pain with butorphanol, tartrate, intranasal, and if so, what situations would be appropriate for its use? I've never actually ran into butorphanol in a clinical setting before. I'm trying to think. Obviously, it's not common enough I decided to add it into my lecture, but certainly I've heard of it. I just never seen it used. I'd actually have to do some looking up and see where to use that. But the intranasals, the big thing with that is just it's good if you need something with better or quick onset, faster onset than oral, but you don't have an IV in place. So that's why I like fentanyl intranasal for like kids that are coming in for like a fracture or something that needs to be reduced, but they don't have IV access yet. You can give that to them. It'll kind of chill them out a little bit, provide some pain control, and that is a really good option until you get the IV established. So I'm not sure. I really just don't see it used very often. Good question though. In terms of conversions, I'm not going to get too deep into this, but this is something you'll run into, especially if you are working without like a pain management service in a place. You're going to find that conversions are necessary because like a patient may come in on a certain pain management regimen that your hospital or your organization doesn't have the equivalent meds for. It may have something different on formulary. So you end up having to do things like switching them out, or if they come in on an oral pain management regimen, but they're all of a sudden NPO for surgery or something, you have to switch them over to IV medications. And again, it's not always 1-to-1. Very rarely is it. So that's why it's really important to make sure you do appropriate conversions. I'll give you a few examples here in a moment. And one of the things we always do is whenever you're switching agents, if I was switching someone from like oral oxycodone to IV Dilaudid, for instance, there's something the patients may experience called incomplete cross tolerance, where even though you convert out the equivalent dose, the patient may still get sort of an over-exaggerated effect because of that incomplete cross tolerance. In order to combat that, we usually reduce the dose down by about 50 to 75%. So if I did a conversion and said, okay, this patient needs 2 milligrams of IV Dilaudid, I'd probably bump it down to like 1 to 1.5 or so in order to account for that. And again, when you are evaluating a patient's opioid regimen, you want to take into account all sources of opioids. So count what they're taking throughout the day in terms of like basal control, and then on average, how many as needed doses do they need to get the full sort of amount of opioids that they're taking. Okay. Here's an example. I'm not going to have you do this on the test, but I thought it was an important enough point to at least illustrate it here. This is just one chart. This is not the only one that's out there. You'll find different ones depending on what the resources are, what the references are. Generally, what they will do is that you take all of your oral opioids that may be on, you convert it over to oral morphine, and then from morphine, you can convert it over into other stuff. So just to show you an example of what this would look like, let's say, for instance, someone was on 5 milligrams of oral morphine. Well, an equivalent dose of that IV is 2.5 milligrams. So it's about half. Right. So if they were getting, 10 milligrams orally at home, Q6, I could switch them to 5 milligrams Q6, and I should be able to get relatively the same effects there. Right. And you can look at the relative potencies between these agents here. So looking at 5 milligrams of oral morphine is equivalent, but only a 0.5 milligram of IV Dilaudid. So if I did a 1-to-1 conversion, that would be way too much. That'd be way too big of a dose for that patient. They're likely sedate, and I'd probably have to reverse it with something. So again, don't memorize these numbers by any means, but just be aware, like double check your conversions, make sure you're not going to overdo it with these patients. Because if you underdo it, you can always give more. That's perfectly reasonable, but that's one of the things you're going to see is that you don't want to overdo it. So just as an example, just to show you guys, let's say we have a patient here who's terminally ill, they got lung cancer. Their current pain medication, they got oxycodone 40 milligrams every 8 hours, okay? So they want to convert it into parenteral hydromorphone because maybe the patient's NPO for whatever reason. Maybe his mental status took a dive, who knows. So basically what we end up doing is you take all the total amount of drugs you're getting per day. So you do 40 milligrams of oral oxycodone times 3 administrations. So you're getting a total of 120 in a day, right? Then you convert it to oral morphine equivalents. So that's that golden rule mentioned on that last slide. And so oral oxycodone is about 1.5 times more potent. So I need less oxycodone than I do morphine to get equivalent amount. So I will go ahead and take that 120 and multiply by 1.5, and I get 180 milligrams of oral morphine, okay? So do I convert that 1-to-1 to IV Dilaudid? No, because the patient would be dead then. So what I do instead is I convert it with the appropriate factor there. And so IV hydromorphone is 10 times more potent than oral morphine. So I do that 180 divided by 10, and I say, okay, he's going to get 18 milligrams of IV Dilaudid per day. That's still a pretty hefty amount. And again, you're going to divide that probably Q6 or however often you want to do it. So still a pretty decent dose there. But again, that's how we go through the steps to make the conversions. And so if you have a nice pain management pharmacist or a pain management service that can help out with this, go with them if you can. Otherwise, you got to do it yourself, and you may want to be just double checking your math there. Another really interesting thing we have available to us is what we call patient-controlled analgesia, or PCAs. Just to backtrack, someone said, in regards to the mechanism of buprenorphine, the tight affinity is what knocks other medications off, and the partial agonist portion is what would make other medications work at 50% capacity if they relapse. Or do I have that backwards? You're right on the first part. The tight affinity is what knocks other things off the receptors potentially, or prevents other things from binding to it. So if I was taking buprenorphine and then I went to go do a dose of heroin, that heroin has a harder time binding to those mu receptors because they're being occupied already. Okay. In the case of overall activity, instead of something like morphine giving me 100% opioid effect, buprenorphine binding only gives me maybe 50%, right? Those are not exact numbers by any means, but it's just a general way to think about it. So that way they help to prevent withdrawal, but you don't get all the euphoric effects you'd expect to see from something like morphine, okay? When someone says only 1 milligram of Dilaudid PO works for their pain and 5 milligrams of morphine PO doesn't, are they just trying to get Dilaudid, or is there an actual difference? So it could be one, or it could be the other. Okay, I won't leave it at that. There are some differences in terms of how patients respond to things. You may find that maybe they've never really received a true equipotent dose. Maybe they've never actually been given that amount, so they're not really sure. Sometimes it's that people may respond a little better than others. So if they really like the way that Dilaudid makes them feel, then that's the one they're going to request potentially, or just maybe works a little bit better for them. I know some people who don't like hydrocodone because it makes them just nauseous as all get out and they throw up all the time, versus other things work just fine for them, like, fentanyl or something. So really, there could be a true difference there, or it could be the other way around. How you can tell the difference? I don't know. I wish I had that answer too. I probably wouldn't be here teaching you guys. I'd be on a yacht somewhere, sipping Mai Tais, or I don't know what I'd be sipping, but something. Anyway, so PCAs are pretty neat because they are basically a pump of an IV medication that is able to provide you a nice basal rate of drug, usually provided as a continuous hourly infusion. That's what we call basal rate. And then there's a button the patient can press that allows for an on-demand dose. Okay, so that way, when the patients experience pain, they can press a button, give themselves a dose, and they should be good to go, right? And so the way these are normally organized is they'll have the on-demand dosing, so how many ever milligrams are going to get per dose. They'll have that basal rate, so that's usually milligrams per hour, and they'll have a lockout interval, so that way they can't just sit there keep hitting the button and then give themselves an overdose. There's usually like a 10-minute lockout period there. And so as an example, let's say we have a morphine IV PCA. They get 1 milligram per hour as a basal rate with 0.5 milligrams every 15 minutes on demand. Oh, there you go. Yeah, some on-demand dosing after delivering the kiddos. Yeah, I know my wife really. My wife was funny with her epidural for both of the kids, because, or at least my first one I remember, because I was looking at her blood pressure. Hers was ropivacaine and fentanyl epidural, and I was looking at her pressure and I was like, "Boy, your pressure's looking a little marginal there. You sure you're feeling all right?" She's like, "I'm feeling fine, and if you tell them to turn down an epidural, I will reach over there and murder you." And I was like, "Well, you can't feel your legs right now, so I don't know if you're going to reach over." She's like, "I will find a way to do it." So I said, okay, I'm not going to tell anyone anything. You're fine. Anyway, so here's an example of what this would look like. So basically the pump is in here. They'll pump the medication to the patient, and here's the button they can press. Keep in mind there are some caveats to using this, namely that the patient has to be like sort of coherent enough or cognizant enough to use it. So if I were to give this to like a 2-year-old, they probably wouldn't understand the concept behind it. But like a 6-year-old, they can probably get that, right? If it's someone who has depressed mental status due to other reasons, this may not be an option for them. So it just depends, right? The point with this is that because the patient's only giving them a dose when they need it, they overall leads to less opioids being required, as opposed to the nurse coming in with an as needed order saying, okay, well, it's been 6 hours, so here's your next dose, because I think you're in pain, so here you go. The patient controls everything, and it leads to less opioids, faster recovery, and all of that, which is great. So the requirements that we need for this, remember, you need the basal rate of drug per hour. They'll have a demand dose. They have the lockout interval there that's usually expressed in minutes, like 10-15 minutes. And then they usually do like a 4-hour maximum. They kind of add up all the 4 hours amount they would get per hour with all the demand doses they can have. So as an example, that morphine IV PCA, they do 1 milligram per hour as your basal rate. Do a demand dose of 0.5 milligrams. They get that every 15 minutes. So because of that, they can get a total of 4 doses per hour. So to total all that up together for a 4-hour total, they could get a maximum of 12 milligrams. So that way the patient can never get any more than that in that 4-hour period. What's really neat about this is the machine will log every time they press the button. So if they if they're using it every 15 minutes, that probably means, yeah, they probably need that medication there. If they're pressing it every 10 minutes, but you set the lockout for 15, then that shows their pain's not under control. So you can look at how many times they're pressing it and figure out, okay, well, maybe I need to bump up my dose. Maybe I need to go up on the basal or change the demand dose, right? If they're not pressing it at all, then they probably don't need it. You can go down on the dose and hopefully get them off a little bit faster. Yeah, we do this all the time for our sickle cell kids. We see this quite frequently in the hemonc unit. We do this a lot for post-surgery. They like this a lot because it helps them get recovered a little bit faster there. So this is a great way to do things for sure. Keep in mind, at least in pediatrics, the funny thing with them is there's one time where we were going through the PCA log, and they're like, okay, well, the demand dose was hit 516 times. And they're like, wow, that kid must be in a lot of pain. And they're like, no, he's got ADHD. He just keeps clicking the button. Bored sitting in his room. So sometimes you got to take it with a grain of salt there. But ideally, you'd be able to use that information to act on it and change the dose sort of based on the data you get back. Anyway, So as I mentioned, for that persistent pain, make sure you have a basal rate plus an on-demand dose being most appropriate. I sometimes will see our surgical or like our anesthesia providers that will sometimes do no basal rate and just have it on demand. So that way the patients don't need like, oxycodone PRN pain. They'll just have the PCA they can have there. And then the demand dose is usually about a quarter to a third of that basal rate in most cases there. And then as I mentioned, the adjustments can be made based on the actual usage and what they're having. Someone said, on the slide for requirements for the PCA order, where did that number 16 come from in regards to doses? So that came from the fact that if you look at this, so because they can get a demand dose every 15 minutes, so they can get a total of 4 doses per hour, those 4 doses times 4 hours would be a total of 16 demand doses. So then when I add all that up, so 0.5 times 16 doses, that's the total amount of demand doses they can give themselves. Yeah, it's good for the RNs too, because then they don't have to come in and administer the medication. They can focus on other stuff than that. And again, the patient has control, so that's kind of a good thing for them. They kind of have a little bit more, feel like they have agency over their recovery, which is great. Anyway, so adverse effects of the opioids, like constipation, super, super common with this one. Almost anyone on chronic opioids is going to be constipated. We just know it happens. We're going to see nausea, vomiting, and sedation being pretty common with these as well. Nausea, vomiting is more related to how the person's going to respond to that one particular opioid. It doesn't happen for all of them. So if someone doesn't really like hydrocodone because they felt nauseous, then you can switch them to something else that may respond better to that. And then the sedation is certainly something you're going to see early on with doses, but they should get tolerant to that over time. So there may be patients who are chronically taking opioids that are driving, and they're fine because they've developed tolerance to that sedative sort of effect there. As I mentioned, histamine release is more so seen with morphine and its derivatives. So, like, certainly I'd lump codeine into that as well, since its metabolite is morphine. So, something to think about. And then less frequently, you're going to see things like delirium and ultramental status associated with this. It's not common with normal dosing. And then we have risk for respiratory depression. This is typically low for normal dosing, but if patients are dosing themselves above what you told them, if they are taking other CNS depressants like benzos or muscle relaxants, this becomes more likely. So this is where you gotta be really careful with this stuff. And of course, we worry about risk for abuse and diversion. Abuse is, again, where patients are taking more than they're supposed to in order to get that euphoric sort of feeling. Diversion is where they're taking it and then maybe selling it for money or for some other drug. So if they really prefer amphetamines, they may sell that oxycodone in order to get their amphetamine. So a big part of things like pain management clinics are urine drug screens, right? So I remember when I was a young naive student, I was talking to someone who worked in pain management clinic, and I was like, well, why the heck would you do your urine drug screen for opioids for this patient? Like, you prescribed it to them, they're taking it. And he's like, well, we don't know they're taking it. Like, it's one of the parts of their contract is that they have to be taking it themselves, and if they do a urine drug screen and they're negative, that shows us that they are not taking it. They're likely selling it, or something is happening to it. They're not taking it. My wife always tells a funny anecdote. When she was in pain management doing her residency, there was it was at the VA, and so she had this pain management clinic she was working at, and there was always this guy that came in on this like hover around scooter thing, but he always had this like lady sitting on his lap when he came into clinic. And this lady was like, he's an older gentleman, but this lady was like, dressed to the nines all the time, always had like the nicest jewelry, nicest clothes on, everything is great. And they're like, man, what is this lady doing with this guy? Like, it seems pretty like an odd couple there, but maybe love is blind. Truly, who knows? But anyway, so eventually, I guess he got cut off from his dilaudid prescription, and then all of a sudden the lady stopped coming in with him. And it was really sad. So maybe there's something else going on. Who could say, right? Anyway, someone's asking. We'll be doing calculations for the test. I would not have you to do the calculation specifically, but I expect you to know like what would be the necessary components of a PCA order. So that'd be good to know, I think, just from a more a technical standpoint. Someone said on the slide for requirements for the PCA order where the number, I think I already said that one. So yeah, that was all the demand doses they can get in a 4-hour period. Okay. So how do we minimize adverse effects? Again, titrate slow. Low and slow is the name of the game here, and try to determine where the side effects are coming from. Sometimes, and again, I had a family member who was chronically on opioids, and they're complaining of like all this stomach pain. And we're just like, man, why are they having all this pain here? It turns out they're just super constipated. They hadn't had a bowel movement in like a week and a half. And so I was like, well, if you can deal with those issues, then that's going to help to relieve a lot of those symptoms there. And if you need to treat adverse effects as appropriate, obviously you can switch to other opioids if they're not responding well to one. They can try a different one. And again, you're going to find that tolerance will develop to a lot of the respiratory, or not the respiratory depression, but the CNS depression aspects of it. Everything will become more tolerant except for the constipation. So in that case there, anyone who's going to be chronically on opioids, we recommend they have a bowel regimen, and this is where we recommend the mantra of mush and push. Again, pretty gross, but I think it does the trick in terms of solidifying in my mind what they require. And basically what that means is you want to have some kind of stool softener on top of a stool, a stimulant laxative. So the mush, emulsify the stools, and then push, meaning a stimulant to kind of get things moving there. Obviously, we'd like to, make sure they're getting plenty of non-digestible fibers and getting good fluid, but usually they're going to require some additional laxative management. So something like Senna plus Docusate makes a lot of good sense when managing these patients here. And then if they need to, you try something else like an osmotic laxative, Miralax, you can try different things to see how they respond to it. So then finally, the opioid antagonists. This is important to know or to have available for patients who may have overdose on opioids, whether it be intentional or unintentional, right? It's not always that they are trying to get high and they overdose. It could be for other reasons. Maybe their pain wasn't controlled and they took more than they were expecting. Maybe they where the pain was not well controlled, so they're taking more than just to get their pain under control. Sometimes they'll do that. But regardless, this is how we reverse those effects. And so this is Narcan. Naloxone is the most common one we're going to use here. And so this is this is not an orally bioavailable drug, so you'll never see naloxone orally for the most part, unless it's combined with something else. But basically, this is something we will give either IV, IM, IN, so you can do intranasal versus intranasal naloxone here, and it's a pure opioid antagonist. This will kick all the other stuff off the receptors. Excuse me. This will kick all those opioids off the receptors and basically reverse the effects. And so if anyone's ever seen a Narcan reversal, it is quite the sight to behold. So if anyone's ever seen like The Exorcist, that could be one example of what this might look like. There's a movie called Bringing Out the Dead with Nicolas Cage and Ving Rhames, I believe. There's a scene where they give Narcan to a patient, to a person who is overdosed on heroin, I believe. And you should check out that movie clip. It is a pretty interesting one and pretty true to life in terms of how they respond. So within seconds, these patients may be going from completely comatose, needing to be intubated, to completely awake, screaming, defecating, just totally, going wild there. Yeah, I lost some good IVs that way, absolutely. Just because they're going to start fighting, kicking, and pulling. Yeah, it's going to be bad news. So ideally, you would not give them that much if you can avoid it. So we can, give them smaller doses and try to get them to the point where at least they're breathing. That's the ideal thing. I don't necessarily need patients awake, but if they're breathing, that is helpful. Yeah, usually angry at the first person they see. I had one young lady who had overdosed on, I forget what she overdosed on in particular, but we ended up giving her naloxone. And the first thing she said when she got up was, "Who gave me that naloxone?" Like, she knew what she got because she woke up so suddenly. And she was very mad that we wasted a bunch of money on her. We were also like, well, you were like close to dead. So, but I guess no thanks for, no good deed goes unpunished, I suppose. Anyway, though, so that's the big thing. You worry about the withdrawal effects here because, again, I don't want to make these patients miserable, but that's what's going to happen if you give too much. So ideally, the nice thing you can do is if you can give small doses, you can actually get them to the point where they just start yawning, and that kind of shows how their brainstem is waking up and sort of responding to that big buildup of CO2 that they have there. It's crazy how mad they get that you ruin their high, even though you just saved their life. Yes, it is interesting. It's certainly in the ER, you see a lot of different types of people, and most of the time they're having the worst day of their life, and so it's just, you get to see a lot of interesting things for sure. But wouldn't trade it for anything. The experiences I've had there for sure. But there's a couple of different ways you can do this. So as well, you can try to use non-centrally acting opioid antagonists as well. So here's a few examples of ones that don't cross the blood-brain barrier, but they work against the GI complications of constipation in particular. So here's a couple of agents like alvimipam, methylnaltrexone, and naloxegol. These three agents here are basically used for opioid-induced constipation to help reverse that. So you'll see this sometimes for like post-operative opioid-induced constipation, try to get their bowels to wake up after surgery and things like that. So you'll see that occasionally, but they should not block any of the effects of opioids in the brain, just on the GI tract. So kind of the best of both worlds from that standpoint. There is another one called naltrexone. You'll see occasionally. That one is orally bioavailable and it's used for a few different addiction conditions, but I'm not going to get that into that too much. It's not used as often as you'll see with things like buprenorphine and methadone, but there are a few other things that are out there. So that's it mostly for the opioids. I want to talk about a few adjuvant and other medications we can use, some of which we might have seen already, some of which we might see coming up in the next section here in behavioral. But this is going to be good in particular for like neuropathic pain. So this is either things to help adjunct medications like your NSAIDs or opioids, or it can be useful for neuropathic pain conditions. And so we'll look at things like the opioid, anticonvulsants. We'll look at some topical or local anesthetics, and then our TCAs can be useful as well. So you should have covered some of these with Dr. Austin as well, I believe. Anyway, and some of these we covered in talking about MS as well, since that's a pretty neuropathic type of pain there. So these are some of the ones we're going to get into. I'll talk about them in more detail as we get to the points. So in the antiepileptics, you'll see a wide variety of these being used here. I probably see gabapentin and pregabalin used most frequently for neuropathic pain conditions like fibromyalgia and things like that. Again, sedation is a common side effect for these. So if they're going to be getting opioids on top of this, you're going to see some synergism there. So again, start low and titrate up. You got time. This is not going to kill anyone right off the bat. They're maybe uncomfortable, but you can slowly work them up to it because you can always give more if need be, right? Again, pretty similar side effects to what we saw in terms of their use in neurology, right? With TCAs, we'll talk about this more extensively in the behavioral section coming up here. These are also good because they help block the reuptake of norepinephrine, and this helps to modulate some of the sensitivities of those pain fibers. So this is why something like methadone may also be good for some neuropathic types of pain, is because it helps to modulate that norepinephrine. So that can be useful from that standpoint as well. And for a long time, this was considered sort of gold standard in terms of management for neuropathic pain. It's kind of going out of vogue a little bit nowadays, mainly because of things like the anti-epileptics. They have a little bit more benefits there, but it's usually the side effects that are the problem with TCAs. So things like anticholinergic side effects, cardiac issues. We'll get into all of that in the next section coming up. So I won't give away too much here, but some other new things we'll talk about. We actually talk about local anesthetics in the surgery section coming up a little bit later on. This is good for neuropathic pains. We think about things like herpetic neuralgias and MS and different things like that. Basically, our local anesthetics, so lidocaine is like the prototypical agent here. Basically what they do is they will block sodium channels on neurons that are transmitting pain signals or in really any sensation. And so basically what they do is normally when they have the cells trying to send a signal, it'll go and hop between these areas of the myelin sheath from those nodes of Ranvier to propagate that action potential. If I block those sodium channels, you deaden that signal. It doesn't get anything sent up in the CNS, which is why you lose sensation. It's numbing, and also why it can be useful for that pain as well. So we'll do this a lot for things like needle stick analgesia. So if we have someone who is not wanting to get or not wanting the pain associated with getting an IV started, this can be useful. So things like IMLA cream, which is a mixture of lidocaine and prilocaine. If anyone wants to know what IMLA means, it stands for the eutectic mixture of eutectic mixture of local anesthetics. A eutectic mixture is basically two things. When mixed together, they lower each other's boiling points to the point where they or lower the melting points. They actually turn into a liquid at lower temperatures. So that's, when you mix the two together, I don't know why I remember that. I had a teacher who thought it was really neat in school, so of course it stuck with me nowadays. But other things include like the lidoderm patches or lidocaine topical patches. You'll see used pretty frequently as well. What I see used a lot more, especially in like surgical, from a surgical standpoint, are like epidurals, which are placed into the spinal column, or like local and regional blocks. This is good for like joint replacements and like really localized areas of pain, like surgical sites. And so these are really good because they're all opioid sparing. So if I have a knee replaced and I have a lot of local anesthetic deadening all those nerves that would normally sense pain, I probably don't need as many opioids because that pain signal never reaches the CNS. So if you see things like ropivacaine or bupivacaine, those are used pretty commonly there as well. I'm going to talk more about those in the surgery section, so kind of keep that in the back of your mind. But certainly lidocaine patches we see used for neuropathic pain all the time. Skeletal muscle relaxants can also be, actually I have a question up here. Someone said, what's your opinion on ER sending patients home with naloxone in order to prevent fatal overdoses? That's a great question. So that's the thing I forgot to mention is that there's been a big push within recent years to get more access to naloxone. That means both not only EMS having naloxone, but police officers having it. That's been a big push in Orange County the past couple of years, which has been good because it's not always EMS that responds to those calls first. Sometimes it's police. And also, sending home prescriptions. And in fact, there's a big standing order from the Surgeon General of Florida that said basically any first responder can go to a pharmacy and pick up an order for naloxone. Not for them necessarily, but for them to administer to someone else. Because again, if you're overdosing on opioid, you're not going to be able to give yourself a dose because you're unconscious usually. I think overall this is good. This is a form of harm reduction, and this helps to, again, I'd rather people be alive and maybe get them some help for their opioid addiction issues, or if they were maybe misusing the medication for one reason or the other. I'd prefer to keep them alive so we can at least try to get them some help. And so I think as healthcare practitioners, you probably want to keep your patients alive too, right? Because again, you think about, you find all these people that come in overdose and you probably get jaded too. You're like, great, I'm going to send them home with naloxone just so they can come back next time. But you don't see all the people that they find dead in their homes, that never make it to the ER. So I think probably from a societal standpoint, it's probably good. I would recommend it to people, but that's my 2 cents, and you do not have to agree with that. That's okay. Someone said, I missed this, but the peripheral acting agents are used as post-surgical meds and not for overdose. Yeah, because if I have someone who has stopped breathing due to an opioid and I give them a peripheral acting agent, they might have like some diarrhea associated with that, but it never gets to the brain stem to stimulate breathing again. Because basically the opioids, they blunt the response to CO2. So you build these high levels of CO2 in the blood that your body doesn't respond to, right? That's why you see them yawn when you first give them small doses of naloxone. When they start to wake up, their brainstem is waking up first and saying, okay, I need to get rid of the CO2. And so that's why they start to typically yawn. Pretty common. Questions? Anyway, so the skeletal muscle relaxants are going to be agents that work through GABA B. If you recall, we talked about GABA A being used with like the benzodiazepines and agents like barbiturates. Sorry, I'm losing my train of thought here. It's the end of the day. But anyway, so these are actually working through GABA B, and the idea is they're trying to help decrease muscle spasms. And you'll see this a lot with some types of chronic pain where patients will have sort of this pain cycle where they experience pain that causes their muscle to tense up, and then that causes further pain, which causes more tensing up. And so you can see how it's kind of a cycle there. By interrupting this, it helps to facilitate better function of the muscles, better mobility. It helps out with like physical rehab, things like that. So these are typically good to add on for patients, especially like musculoskeletal issues that they're experiencing here. Keep in mind though that these are all very sedating. So these are going to be synergistic with other meds they might be on, like they're on gabapentin or if they're on an opioid or something like that. So you do want to be cautious when mixing and matching these. Because sedation it'd be nice if it was actually a true muscle relaxant, but it's really doing it from the brain, which is why you see that sedation happen there. Lots of agents here, so baclofen, cyclobenzaprine, metaxalone, methocarbamol, tizanidine, just to name a few. This is always like a really common thing I would see in the adult ER as patients come in that would be overdosed on an opioid, a benzodiazepine, and a muscle relaxant. Is a very common trifecta. So I really caution people not to use those three together because, again, these patients maybe didn't intend to overdose. It was just the fact that there was just way too much for them all at one time and they got into trouble. So be really cautious with using these three. And notice there's not a good way to reverse many of these besides the opioids. So even if I reverse the opioid effect, they still may be seen as depressed from this stuff. They still may need to be intubated. So just something to consider there. Someone said, do you feel like it could have an adverse effect and end up enabling more drug use because they know there's a way to come back from trying to get an extreme high and overdosing? That's another good question. I would like to point towards, and again, try to use data whenever possible, right? There was a very interesting sort of experiment done. I think this was done several years ago, but I think it was like in Vancouver. This is like a type of thing we couldn't do in the US, at least in recent years, but this is done in Canada, where basically they took an area that was like a very high amount of like IV drug abuse, including opioids, and they basically made like a safe site for people to come in, and they could actually have a nurse on staff, they'd have a doctor on call, and patients could come in with their drugs, and they would be supplied clean needles, they would have clean supplies, everything like that. They could use the drugs while they're still being observed by a nurse. And then they'd have like a room where they can go and like chill out or do whatever. And then what was interesting is they also had like offices on top of that building to where like, hey, if you're homeless, we can try to find you services to get you homed. If you do not have a job and would like one, we can try to find you services to do that. So there's a lot of social help involved with the program too for people that were ready for that. What was really wild is that you end up seeing a huge number of decrease in the overdose deaths, right? Which is good. You saw a big decrease in the amount of transmissible diseases like hepatitis C and HIV. And you overall saw this like big, and if you look at like the heat map of like all the IV drug abuse and stuff like that, there's a big decrease right in that area where that safe site was. So I think there are some benefits to harm reduction. And I think as time goes on, we'll see probably, I hope that will bear out. This is probably a good thing. I don't know how many people that overdose and want to say, man, I want to try that again. Again, this is a compulsive sort of thing. I don't think they're doing it necessarily on purpose in order to die. This is usually not like a suicidal kind of thing. It can be, but it's not generally so. So I don't know. That's kind of my thoughts on it. I think overall it's probably good. But you'll find a lot of people that will disagree with me, and everyone's opinions are certainly valid. But it is what it is. Anyway, so getting into capsaicin, we've talked about this, I think, briefly before. I think we talked about it in the ortho section, or no, talking about with osteoarthritis. So this is again good for yeah, I'm glad you find it interesting. Other people might as well. Do your own research on this stuff. I think it's really wild, and I think the kind of social sort of implications of it are really interesting, and it's crazy to see how things have advanced even nowadays, and like with medical marijuana being available in Florida. Like that was wild to think about if you consider where Florida's kind of at in the grand scheme of things compared to other states. So things are changing, right? So we'll see how it ends up in 10 years, maybe totally different. But capsaicin is also not only good for like osteoarthritis, but you can also see it being used pretty effectively for neuropathic pain conditions as well. Same thing here is that, again, it works by depleting substance P. So while you're using it initially, it doesn't feel too comfortable. It feels pretty hot, maybe painful a little bit. But if they use it consistently, deplete that substance P, it's pretty good. But they got to be consistent with it. And remember, have them wash their hands, soap, and water, okay, to get rid of that capsaicin. Or just use gloves. That's another really good way to avoid that if at all possible. I'm not going to belabor that point because we talked about that in the room stuff earlier. Now, I could have included tramadol here along with the other opioids. I kind of separated it off because its use is a little different. Like you don't usually use tramadol as an alternative for a true opioid and vice versa. So tramadol or Ultram is a partial agonist at the opioid receptor. So it doesn't get the same full effect as you would see with like full-on morphine or something, but could be good for more moderate to moderately severe cases of pain. I'd probably say it's stronger than codeine, but not quite to the effect of like a hydrocodone, oxycodone, kind of in the middle there. The other benefit that it has is it has weak inhibition of reuptake of serotonin and norepinephrine, so that's why it's good for the neuropathic pain side of things there, right? Now, for a long time, this was not a controlled substance. So as an advanced practitioner in Florida, if you're an NP or PA for a long time, this was like your go-to pain medication. This is the strongest thing that you could prescribe for a long time in Florida. So it got used all the time. You see scripts for this frequently. But after a while, we realized that, yeah, there is some abuse potential to it, and actually got made a C4. So that did change the restrictions around that. So that's something to know. But you guys have access to it again now that with the House Bill 21, should you get your DEA license and all that. Anyway, note here that in terms of side effects, similar effects to the opioids, maybe a little less so. I do worry about like seizures with this one in particular. I've seen that because of the neurotransmitter effects. You can't see seizures and overdose, but that's not something you would see with routine use pretty commonly. Also, it doesn't get fully reversed with naloxone, so that has been a bit of a challenge. If I see a tramadol overdose, I can't just give a dose of naloxone and reverse it. It can be a little more challenging. So you may find some versions with acetaminophen in, so Ultracet, that's that CET in there. So that's that combo. Now, talk a little bit about medical marijuana. We've discussed this a little bit already when we talked about the synthetic THC compounds like nabilone and dronabinol. But as of 2016, medical marijuana has been available in Florida. And again, the law sort of states it as, and it gives these different indications here, which are all things that medical marijuana has shown efficacy against. However, they put this disclaimer at the bottom, just basically says whatever the physician thinks might be useful for, go for it. Maybe if the benefits outweigh the risk, go for it. Let's see how it works, right? So you kind of have carte blanche to kind of use it for lots of different things, rather than just what's on this list here. So it's, it leaves it a little bit open there. If you recall, we talked about how delta 9 THC or tetrahydrocannabinol is sort of like the main psychoactive compound of marijuana. We talked about it in terms of the use as an antiemetic and use for its appetite stimulating sort of effects here. But we see it's useful for a lot of other things. So there's some pain things this can work for. The cannabidiol or CBD has had use for certain types of seizure disorders and as a anxiolytic. So a lot of use for these things here, and was interesting. I was talking to a medical science liaison that worked for the company that makes the only FDA-approved CBD product called Epidiolex. It's for 2 types of seizure disorders, and to talk about their research that they're doing about all the different targets here that we just haven't identified yet. There's so many places that marijuana works in the brain that we just don't know about. It'll be interesting to see where things go in the years coming. Now that hopefully we can get a little bit better research done. We'll see if it gets, who knows if it'll get taken off the Schedule 1 list. That'll be interesting to see what happens in the next couple of years here. But at least what we know so far is that the 2 primary receptors that it works on is CB1 and CB2. CB1 is the primary one we're going to focus on in terms of its work in the CNS and for pain and things like that. CB2 is more found in the peripheral tissues. But again, it has a lot of complex effects. We just don't know everything about it, unfortunately, just yet. This is a picture of my basement here. Pretty voluminous here for Florida, but just kidding. It's not my basement. I don't have a basement. It's my shed out back. Anyway, so in terms of medical marijuana, the things to be cautious with, because again, they can have some benefits for a lot of the conditions I just mentioned there, right? So you will find that there are plenty of studies that show some benefit to those conditions. So I don't think it's a question anymore of whether medical marijuana works. I think it can work for sure. But again, knowing the risk is also important too, because I think a lot of people think that it's like completely harmless, but that's not true. There's some issues here you can run into as well. So certainly impaired judgment, motor coordination is going to be affected here. So definitely they can be just under the same sort of CNS depression as you would see with like a benzo or something like that. So again, no driving, no operating heavy machinery, probably not take it before class. That would obviously probably be a bad idea if you want to pay attention. And for some people, especially those that have like pre-existing psychiatric histories, you could have issues like paranoid ideations. Psychotic symptoms are possible, but are still pretty rare. In terms of like long-term effects, we kind of don't know because it's been very difficult to do research here in the U.S. As a result of its Schedule 1 classification. It was just hard to get a hold of, and the stuff that we could do research with was just not very good, as it turns out. So we don't know the full effects here. There could be issues in terms of long-term memory impairment. Who could say fully? But again, be careful for those concomitant psychiatric histories because it can lead to a little bit of exacerbation there. In terms of how patients are going to be getting what dosage forms you're going to use, again, I don't like the kind that you traditionally, like a joint or something you traditionally have to light up. Again, a lot of that hot gas can be damaging to the lungs, just like nicotine-based products could be. So again, you want to be careful there in terms of like reactive airway disease, can cause bronchitis. Nowadays with the vaping solutions, that may be a better alternative. Although a lot of the additives and that stuff, we don't really know a lot of information about, things like propylene glycol and things like that. So who knows what that's going to bear out in the future. And then with edibles, you do have to be a little bit careful there in terms of its pharmacokinetics. You'll find edibles tend to have a little bit of a delayed onset of action, which can be throw people for a bit of a loop. But I don't want to get into that tangent just right now. Anyway, so be careful with the pulmonary stuff if they're going to be smoking these products here. And overall, this is a meta-analysis back in 2015, so it's a little out of date, but I still think it bears the points that this is done in the New England Journal of Medicine, I believe. And they basically say that with medical marijuana, yeah, there's plenty of studies that say, yeah, it probably works, but there's nothing to say that it's like a slam dunk, like better than the gold standard pharmacologic management. So I would say that if a patient wants to try it, and it's reasonable, they don't have any contraindications, they can have a medical marijuana provider that can sign off on that, then I say go try it. It's fine, If they have failed standard therapies and would like to give it a try, I say it's a really good time to do that as well. To use it as first line, I maybe would shy away from that unless they really had, a predilection towards going the marijuana route. So again, it's going to be based on that conversation between patients and the providers there. So overall, this is basically what the JAMA was saying. think that's a New England Journal, but it was JAMA actually. So again, make sure that you look to see like, hey, can you use, have you used, first line agents, second line agents? Have you tried the FDA approved cannabinoids like dronabinol? And if those still aren't working and they don't have any psych history, then yeah, maybe go ahead and try it at that point. So kind of hedging their bets there a little bit. So overall pain management is complex. It needs to be individualized to the specific patient there. And again, think about which drugs you're using, how you're combining them together. Think about the adverse effects and all of that, and how we can manage side effects. Those are going to be the kind of the big points I'll probably be pulling off like test questions. But I'm going to cut it off there for today from that stuff. I have a few questions here. Someone said, had a friend who said marijuana helped him focus when studying, but had a hard time remembering what he studied later on. Well, isn't that just the double-edged sword, huh? He could focus better, but couldn't remember what he studied. I don't know if that's any net benefit for that person there, but it's pretty funny. Someone said, I'm not sure if you mentioned this, but what happens if someone's given Narcan and is not having an opioid overdose? All right, this is actually fascinating. If you have someone who is opioid naive and you give them a huge dose of naloxone, here's what happens. Nothing. We don't have a whole lot of endogenous opioids that are around or expressed, at baseline. So if I had someone who overdosed on, so actually this is an important, good point. Let's say you have someone who comes in who has depressed mental status, altered mental status. They're found, I don't know, passed out in their car on the side of the road. State troopers found them and now they get brought in via EMS. And your job is to figure out, why do they have this depressed mental status? Does they have meningitis? Do they have hypoglycemia? Is it drug overdose? What could it be? That's so funny. Gonna build up the anticipation, then bring it back down to reality. But basically, if you have someone like that, you can kind of give Narcan with impunity because best case scenario, they wake up and you have your answer. There's probably opioids that is responsible for that CNS depression. Worst case scenario, you reverse the opioid in their withdrawal, but you also have your answer there. Or in the middle, nothing happens, right? So, and that's another thing too, is they'll have a lot of providers who will have someone in that state. They'll do a urine drug screen and it'll be negative for opioids. And they'll say, okay, well, it can't be an opioid. No reason to give naloxone. I'm like, well, hold on a second. Like, there's some opioids that don't show up on urine drug screens. A lot of synthetic ones don't show up. It doesn't mean it can't be an opioid at play. So, again, there's so little risk with giving it. You might as well try it and see if it works. If they wake up, they wake up. You guys can leave if you want. I'm kind of done, but just there's something called the coma cocktail. That is something that's kind of kind of an old school thought, but it's something you can give in order to try to wake up a patient with depressed mental status. And it basically includes naloxone, it includes dextrose, it includes oxygen, and I think thiamine is like kind of the other one they kind of think about, the alcoholics having encephalopathy. Those are kind of the big things to try to administer to see if they're going to wake up. And if they do, then you have your answer, right? Or if you do an AccuCheck and their sugar is 30, okay, we'll give them some sugar and that should wake them up. So anyway, just something to kind of consider there. But yeah, if they're opioid naive and they don't have any opioids on board, I can give them all the naloxone in the world and they probably will not have any issues with it. Well, all the stuff in the world probably just drown them or something, so I probably would kill them. But I can give them very big doses and they'd be okay. Any other questions? If not, thank you for joining me today. I really appreciate you guys. And otherwise, I will see you all tomorrow for day 2 of 3. Thank you. Have a great day.